is Dr. Indu Narayanan. She will be speaking on evaluating the watery eye with congenital dacryocystitis. She is a oculoplasty surgeon. She was with us in LF for a while and now at Comtrest, Talisheri and Calicut Comtrest. Okay.
Good afternoon, everyone. I thank Laila ma'am and KSOS for giving me this opportunity. So I have been interested with the topic evaluating the watery eye. So to begin with, it is very important to understand the anatomy of the lacrimal drainage system. It starts directly with the puncta, the canalicularis, and there is a common canalicularis, continues as a sac, and inferiorly it progresses as the NLD. So there is two valves which are important. This is the valve of Rosenmuller, and in the inferiorly there is the valve of Hasner, and it opens at the inferior meatus. So a block anywhere along the drainage system can cause epiphora. The most common cause of epiphora in children is of course NLDO or congenital nasolacrimal duct obstruction. But it is very important to rule out all other causes, like look for the lid malpositions if they have the epiblepharon or congenital entropion or any lash abnormalities like trichiasis. Always have a look at the puncta, whether there is any punctal agenesis or stenosis. And it's also very important to understand the embryogenesis. So a few words. Here it starts with an ectodermal thickening to form the lacrimal cord. The lacrimal cord canalizes, and it is very important to understand that the distal site, that is a valve of Hasner, is the last to canalize. So in around 60 to 70% it is imperforate at birth. So this imperforation, it clears by first month of life in about 95% of the cases and 96% by 1 year. That is why the age of 1 year is very important. I would like to bring to this diagram. Here you have the inferior, this is the inferior turbinate and this is the floor. So the usual NLD, it opens into the inferior meatus. So here are the variations in NLD. Here in the picture, it is opening in the vault of the inferior meatus. NLD, here it is coming down and opening in the floor, and the NLD is impacted on the inferior turbinate. Here it is on the anterior aspect of the inferior turbinate. It is blindly ending into the maxillary sinus, and here there is no NLD. So what happens is that all this causes congenital nasolacrimal duct obstruction, and this is called as complex CNLDO. Now, clinical features the child presents with watering, discharge and matting of the lashes, and it usually worsens with the URTI. So it can also present as cystic swelling below the medial candle tendon, which is called as a dacryocystosis, and also as lacrimal fistula. So a few, just a word about the dacryocystosis. When it causes, when there is, along with the NLD, when there is a functional obstruction of the valve of Rosenmuller, it causes the dilatation of the sac, and that is dacryocystosis. And this, along with the dilatation of the distal part of the nasolacrimal duct, it causes intranasal cyst, which is seen in the endoscopy like this. So this causes respiratory insufficiency in infants because they are nasal breathers, and in a bilateral case, obviously, it is a life-threatening condition. So examination, unlike in adults, it's very difficult because you can't do a syringing. So basically, there is an increase in the triofilm height, and fluorescent test is disappearance, dye disappearance test is positive, and always look for RO+. So these are the syndromes associated and the abnormalities associated. So the treatment, until 1 year of age, you need not do anything. Basically conservative treatment, not anything, but you have to ask them for lacrimal sac massage or compression. In case of purulent discharge, topical antibiotics are prescribed. So the idea is that it increases the intraluminar pressure and to rupture the valve of Hasner. So the technique, it's very important. Always instruct the bystander, I mean the parents, how the technique is. Okay, and it's very important to know that they have studied it properly and they are doing it in the correct way. So you always use the index finger and just inside the anterior lacrimal crust below the medial candle tendon, and It can be done about 10 times a session, 4 times a day. So once it is 1 year of age, still the child is having watering. What is next? It's probing. So probing, it's recommended under general anesthesia because it's more controlled probing, and you can evaluate the lacrimal system. Also endoscopic evaluation as well as the treatment of nasal pathology is also possible. So now about the technique of probing: decongest the nasal mucosa and use the punctum dilator. Punctum is dilated. The probe is introduced just with a stretch on the lower lid or the upper lid, whichever. And the probe is directed now in the horizontal direction and until you get the heart stop. So when heart stop is reached, just withdraw by 1 millimeter and then gently direct it vertically and direct it along the direction of the NLD, that is lateral, inferior, lateral and posterior, until you get a gentle soft stop, this giveaway feeling is obtained. So, and also look at the endoscopy and see that your probe is correctly, it is visualized under the inferior turbinate in the inferior meatus. So why endoscopic assisted probing? Because it gives a direct visualization of probe and avoids the false passage. And also that you can diagnose the NLD variations and also treat the intranasal abnormalities if any. So even after probing, if there is a recurrence of symptoms, it's called as a failed probing or persistent CNLDO. So this occurs mainly in complex CNLDOs or associated proximal obstructions or in a case of dilated or atonic sac. So what next? You can repeat the probing or a probing with silicone intubation. So this is a 56% is what the literature says, the success rate of repeat probing, and 84% if it's along with the silicone intubation. So when is a DCR indicated? If it's a multiple failed probing or if it's a case of complex CNLDO or a bony obstruction. If you're feeling the bony obstruction at the time of probing or you get an atonic sac, you can directly convert into a DCR. So the age of DCR recommended is about 4 to 5 years because for the pneumatization of the sinus and the maturation of the bones. But early DCR is even reported many times in some case series, even at the age of around 8 months. So just a slide on the dacryocystitis management. It's basically conservative by sac compression, but if it is associated with an intranasal cyst, marsupialization is required. And lacrimal fistula, it usually spontaneously closes after the closure of NLD. After the NLD resolves. And if not, fistulectomy can be done. So my take home message is that always check on the parents' technique of sac compression. They may not be doing the correcting, and have an idea about the complex CNLDO, and endoscopic assisted probing is thus recommended. So I would also like to invite for our National Conference of Oculoplasty next year. It's conducted in Kochi and the month of April 24, 25 and 26. So I would like to invite you all for the same.